I first of all became interested in the world of neurology in my second year of medical school when we first started doing our neurosciences module. And for the first time, everything clicked. That you had a map, which was the brain and the spinal cord, and you could actually find out where in the brain or in the map the problem is just by looking at the patient. And that intrigued me as to how one maps the other, and you can follow and figure out where the problem is. And then as time developed and I started to learn more about it, you then understood all the different myriad of pathologies that can happen within this one organ. Within the actual work field, I'm someone who likes quick results. I'm someone who likes to think very much on the spot. I kind of like to be under pressure. So as time went on, I then was able to come to St George's to do one of my junior doctor jobs, and pretty much that was all in stroke and neurology. And that is when it all came together, where I was able to do neurology, figure out the brain, the map, what's wrong with the patient, but at the same time, we have to make time-orientated, quick decisions in order to get the best out of the patient and get the best results for them. And at the same time, you had a great team to work with. You had nurses, you had junior doctors, you had therapists, A&E departments, everybody working together to try and help this one person as quickly as possible, because time was very important for a patient with a stroke. All in all, it provided everything that I wanted from an exciting career that's hopefully going to keep improving with all the developments that are happening. So immediately after the hullabaloo of providing the treatment and getting the people on the ward, or even for the patients who haven't come in within the time frame to have any of these other treatments, the mainstay is then keeping them medically stable initially. So it's the change in the brain, keeping their blood pressures nice and stable. So in the immediate aftermath of having had a stroke, it's very important to look at any other medical problems that may happen. So chest infections, keeping them nourished, but not necessarily overnourished. We have to make sure that they can eat and drink and not aspirate, i.e. not let the food go into their lungs. Nursing, so turning and looking after their general nursing needs. And then when things are a little bit on the calmer side, it's trying to look at the recovery and the rehabilitation. There has been a lot of work so far which has shown that you probably need to start, or you're safe to start rehabilitation from about 24 hours on after a big stroke. But for each person, it has to be individual and graded, because big strokes need slightly slower rehab initially, and smaller strokes you can probably push a little bit harder. And that's where the physiotherapist, the occupational therapist, speech and language therapist come in. The other things from the medical side is obviously prevention. So once you've had the stroke, it's our job then to figure out why you've had a stroke and how we prevent another one from happening. So whether that's looking at the heart or other blood vessels and then trying to treat that or reduce the risk of having another one by looking at that. So it's both a medical and a rehabilitation side. Most strokes which can be discharged are nowadays discharged home, with rehabilitation getting in as early as possible at home, and that's something we call early supportive discharge. Strokes that stay within a hospital, once they've dealt with the hyperacute side, so all this early treatment that we give, once all that has settled down after about 72 hours or so, they ideally then go more towards a stroke unit bed where there's a little bit more rehab available, so they get a little bit more time every day with the therapists rather than the doctors, just to rebalance it all. And once all of that is stable and it feels like they need a lot more rehabilitation time, then they may be referred for longer term rehabilitation. All of these things are goal-directed per person, so it requires a lot of effort from the multidisciplinary team. So there's usually a physiotherapist, a speech and language therapist, it could be a psychologist, an occupational therapist, and the nursing team. So all of them, plus the medics, kind of have to plan what they think the patient is going to achieve and then set a goal for the patient to try and reach to each time. So it's not something that you can roll out to everybody as a program. It is an individual approach that has to be done in rehab. So I started working in 2004, and the breakthroughs that have come through from there have been twofold really. I qualified in 2004 from medical school, and at that time nobody really was that interested in stroke medicine. It was felt like an incurable condition. There wasn't really much effort and funding that had gone into stroke care. There wasn't really much emphasis in the secondary prevention side very much either. Some centres were doing it, but it wasn't a big national thing. And then when I started at St George's, I realised actually, not only in this centre but throughout the country, things are changing. And the things that had changed at the time was a drug called alteplase, which is now the mainstay treatment of all clots in brains within a certain amount of time, so within 4.5 hours, which are there for people who've come in with a stroke. And you could give this drug and it helps, if given early enough, 1 in 8 people. And obviously, being physicians, we weren't satisfied that only 1 in 8 were improving, and there were a large amount of people that we weren't able to help because the clots were too big. And so the evidence came through in 2015 to use technology to pull out clots, and then we became the first centre to provide this service 24 hours about a year and a bit ago, where we're able to actually help 1 in 5 people who have had very big strokes by just pulling out their clot, as long as they get to us within, again, a very short time space window of 6 hours. But again, the sooner the better. So there's a lot of developments that have happened, but all this stuff has happened in the past 5 to 6 years, where it's revolutionised how people manage patients with stroke. There's a lot more interest now because it's not an incurable condition. You can do something about it as the stroke is happening, and that is actually getting a lot more people interested in talking about it.